Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is MIPS 101, a refresher. PYA is happy to present today's webinar on this important topic. You may submit questions through the webinar by typing a message in the questions pane of the control panel. Also, immediately following the end of the webinar, you will be asked to complete a short survey and submit any additional questions. We will respond to questions posed after the webinar via email. We have posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you will receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenters, Lori Foley and Martie Ross.
Hi, everyone. Thank you for joining us. We are excited to visit with everybody today to talk about MIPS 101. We're going old school and going to do a refresher on MIPS. We've, through working with our clients and answering questions along the way, we see that there's a cadre of individuals who may have come into the MIPS program not from its very inception, so either stepping into a program and trying to continue to navigate it forward and not certain why some of the things are the way they are, or brand new to the position and MIPS as a whole. So we thought it would be a good time just to step back and revisit, just go back to those basics for MIPS. So I am Lori Foley. I am a principal with PYA. I lead our Revenue and Compliance Advisory service line. I've been with the firm for 24 years and have lived intimately within the MIPS space, assisting providers, both individual physicians, individual groups, private practice groups, and large employed physician networks navigate through their MIPS experience, which has been a lofty trail as we've gone through, a lot of learning in the trenches and a lot of movement in the system. And pleased to join Martie Ross today on this Healthcare Regulatory Roundup to talk about her favorite topic of MIPS.
Ooh, alternative payment models, exactly. So I'll bring up the back end, but Lori's going to do most of the heavy lifting today.
Perfect. So we have a couple of our agenda for the day is to review high level just for a moment the quality payment program overview. Then we'll dig deeper and spend the majority of our time in the merit-based incentive payment system, MIPS by our daily acronym. And then as Martie referenced, she will bring up the rear there with focusing on APM and advanced APMs. But first we are introducing a Slido today. Some of you may have done this with us before, but if you'll take a moment and join us at slido.com, you can scan that QR code. If you go to the website, you input that particular number. We have a quick polling question too on the front end just to get to know our audience a little bit better and see a little bit of the variety of ways that people are approaching our conversation today related to MIPS. So if you have your camera on your phone, go ahead and take a picture of that, go to your website, put in that number. Our polling questions are right off the bat, so giving everybody just a moment to do that. And then we will go to our first question. So I'm curious as to who's in today's audience and which of the following best describes your situation. Are you well versed in traditional MIPS? You've grown up with the program, you're just getting some additional information. Is this new for you? Are you in a MIPS APM or an advanced APM? We're curious to see what everybody's experience is as we navigate through. Give everybody just a moment there. All right, so we have lots still coming in and a lot of movement, which is always fun to see. So it looks like a lot of desire for information on those APMs and AAPMs, and that makes sense. We know that Medicare is one of Medicare's ultimate goals is to steer providers to that for a variety of reasons I'm sure Martie will touch on. Some of you that have stepped in as a late adopter, if you will, into MIPS, and then I think we're going to get everybody covered. We have a very few, which makes sense, of those that have actually grown up into the program with us. So thank you, very helpful to see that. So looking at our next one, based on your program and what you know about it, please select any and all that may apply. So we've listed all the varieties of how you can participate with MIPS, how you can report, how you submit information. You'll see as we scroll down if you're reporting individually as a group, and whether or not you have that information or you're still trying to find that out. We'll give that just a moment. Okay.
And worry not, all Slido is anonymous, so.
Oh, that's right. I
Follow
forgot
up
to
here.
tell you. You are among friends. No judgment
Exactly.
zone. No judgment zone. All right. So as we're looking, there's a number who don't know. We've got some group reporting, a good bit of traditional. The others, they're not exclusionary. So obviously multiple apply. Things that jump out at me is still, we've got some early adopters, it looks like, on MIPS value pathways. We'll talk about what those are and how that's changing our MIPS trajectory for a number of practices and individuals as we go through. But thank you, appreciate everybody participating. This gives us some good context as we have our conversation today. So with that, we will go ahead and jump in and talk about the Quality Payment Program, or QPP, from a high level and an overview perspective. So if you've been in healthcare for many years, as Marty and I have, you might recall the sustainable growth rate process prior to the Medicare Access and CHIP Reauthorization Act of 2015. Every year, providers sat on the edge of their seats to see exactly where reimbursement was going to go for the following year. And there were big swings in the predicted impact to the fee schedule. It was going to be cut 15% or 30%. Big adjustments that were difficult for practices to plan around and make, just strategic decisions around to know exactly what their Medicare reimbursement was going to look like. That process typically ended with a save or a fix coming in through some sort of legislative remedy that then reverted to a very minor adjustment. It might be up 2% or down 3%. Something that was drastically different than what was proposed and anticipated through the SGR. And really the SGR became unsustainable and non-predictable. So Congress took action. They created the Medicare Access and CHIP Reauthorization Act in 2015. That created the Quality Payment Program, which launched and became kind of kicked off in January of 2017. And what it did for Medicare payments, in particular related to professional fee services, Medicare Part B, was really, start the transition within the routine payment model of moving to value instead of volume. So it gave CMS the, the ability to reward value and high quality physicians that were providing that high value through penalties, essentially reductions in payment for providers who are not providing that same level of care. As it navigated through, it created two tracks of payments, which we will talk about today, really being what we referred to earlier with the MIPS being one, the traditional MIPS, and then the second being that advanced payment model, the APMs. And as we'll talk through those as we move forward. So you can just see here kind of the graphic on how CMS portrays those two paths, those two tracks through the QPP. So think about QPP. Macro created QPP. QPP is the overarching umbrella for the program, and then traditional MIPS and now MVPs, and then APMs kind of are two paths that roll up underneath that. Medicare has some specific goals. CMS has some specific goals related to the QPP program. I don't think there's anything that's earth-shattering here, but it really is to improve beneficiary health. And a key goal at the end of the day was to lower cost and improve care, but also improve health for its population. And they were very upfront and have been from the very beginning that one of its goals is to expand that alternative payment model participation. And there's a number of reasons for that Marty, I know, will go into. They went on a roadshow, they've asked a lot of questions, they've done a lot of listening sessions and sought a lot of input. That continues with each proposed rule year. So as we talk about some takeaways from today, some opportunities to weigh in and provide input on how MIPS is impacting your organization and your providers. We always promote that, that participation. And then we get feedback through your participation in MIPS to see how your providers are comparing to other providers in the population. So digging where we're going to spend most of our time related to MIPS program itself, let's just start at the basics. So from an eligibility perspective, eligibility for MIPS is based on a combination of taxpayer identification numbers, or TINs, and national provider identifiers, NPIs. And so you'll hear the reference TIN NPI combination a lot. Providers can have multiple TIN and NPI combinations. Think about your providers who provide services at 3 or 4 locations. Each location is individually evaluated based on that discrete TIN NPI combination. So when we talk about looking at a provider's eligibility, and you look them up on the QPP website, you can look up a provider, drop in their NPI, and you will see that they have 3 or 4 entities for whom claims are being filed under that provider's NPI, and they're evaluated individually at each location site of service based on each tax ID site of service based on that participation. There are 3 low volume thresholds that providers must exceed in order to be required to report for MIPS. And so when you look at the website, it will say they're MIPS eligible. I liken eligibility to required, meaning if they're eligible and it's affirmative, they are required to report. So those 3 low volume thresholds include billing more than $90,000 for Medicare Part B covered services. So think payments. They will refer to it as charges, but in reality, it's defined or calculated based on actual payments made. They see more than 200 Medicare Part B patients, so individual patients as a count, and they provide more than 200 covered professional services to those Medicare Part B patients. There are also 2 periods considered when they look at this MIPS eligibility. So 2 12-month segments, unless somebody just comes into segment 2. So a provider joins an entity, a tax ID in segment 2, then they are not going to look back. Obviously, there's not history to capture for that. But otherwise, for providers that are stable within an organization, they will look back to segment 1. So for our 2024 performance year, that first segment is October 1st of 22 through September 30th of 23. And segment 2 is the same for 23 and 24. Almost all clinician types now are eligible for MIPS. It started very small with physicians and nurse practitioners and has grown to expand to include all of the types of provider and clinician types that you see here. So most anybody who's billing on the Part B fee schedule and being reimbursed is considered an eligible clinician. There are certain times that there may be changes to eligibility. Generally speaking, if you are not eligible in segment 1, you won't suddenly become required to report in segment 2. However, if you are eligible in segment 1 and situations change in segment 2, you could fall off that requirement to report. Other things that may create those changes is if you have a new practice or an APM entity, if you're changing provider types or specialty codes from one segment to another, if you fall below those low volume thresholds in that second segment, and then some additional circumstances related to APM participation and qualifying provider status.
Hey, Lori, just of note, MedPAC in a recent report on the QPP program provided data for the most recent available performance year, which was 2021. So that was the payment adjustment 2023. And of the eligible participants, 460,000 did not have to report because of the low volume requirement. So it's a pretty significant chunk of the provider population that ends up not being subject to MIPS because of relatively low volume of Medicare beneficiaries for whom they provide services.
Absolutely, and that's one of the reasons that if you're evaluating, some providers come into MIPS because they start billing, or they come into CMS, they start billing Medicare, and they're trying to figure out, really each year you need to look your providers up to see, because it may change and you may have providers that you think. And the other piece is, remember, this is only related to traditional Medicare Part B. So Medicare Advantage claims are not included in this analysis. So areas that have a high concentration of Medicare Advantage also, I think, leads to what you're seeing there, Marty, in those numbers. So you can, for your organization, designated representatives can log on and get the full roster for all the clinicians in a practice. So that's obviously the most efficient way to do it. But you can also just look up on an individual basis by dropping in a provider's NPI into, you go to the QPP lookup, you drop in their NPI, you click all years, and it will show you chronologically for years. So make sure you're looking at, you select the correct year that you are looking at. But when you look at that and do that, you will get information that will be returned, again, based on every NPI tax ID combination, information about that particular provider's eligibility for each of those tax IDs. So for example, in this provider is not individually required to report. If they were, it would be a little green box or a little green check mark like this is for the group. So this means that individual, and you can see they'll give you the details, they didn't exceed the low volume threshold, they didn't exceed 200 patients, $90,000, and they didn't have 200 services. So they are not required to report. In certain circumstances, they can opt to report. And if they report as a group, then they get pulled along. Here you can see that the group as a whole did meet those thresholds. They exceeded the low volume threshold of 200, 90,000, and 200. So when we talk about whether you report as an individual or a group, it's a strategic decision. If you have a group of 100 providers and only 3 providers are required to report, if you're confident that you're going to score well, then you may go ahead and report as a group and it will pull everybody along. If you are not confident, then you may just want to deal with those 3 individuals and not impact the group as a whole. Because when we talk about scoring, those scores as a group would impact everybody that bills under that tax ID number going forward. Martie also referenced as well that and we'll talk about it in a minute, the performance year is always 2 years removed from the payment year. So we are in performance year 2024. The impacts of this year will be felt in the reimbursement for 2026. There are also some special statuses for certain providers, as you see here: ASC, hospital-based, facility-based, non-patient facing practices, a number of considerations for small practices, those in HPSA and rural. And that same lookup that we just looked at, if you scroll down at the clinician level and at the practice level, group level, you'll see if a provider has a special status. It'll just articulate it there. If they don't have any, it won't show anything. It won't show a no. So when we look at the composite scores, so there are 4 components to MIPS, and you can see here the weighting. I thought it was interesting just to show how they have shifted over the years from a payment year perspective. Really, statutorily, part of the goal or part of the rule required CMS to get to the point where quality and cost were equally weighted. And so you can see when early in the program, it was 50% quality and 10% cost. And over time, it has shifted so that it's 30% each. Those are equally weighted, with promoting interoperability and improvement activities remaining unchanged through that time. And again, that 2-year lag. So you'll see, what you do today takes a minute to get submitted, scored, results, and then hitting the fee schedule in 2 years. From that scoring perspective, you have to have a minimum of 75 points in your composite score, so adding up all of the categories, in order to have a neutral adjustment. No positive, no negative change to your reimbursement in 2026 for the, whether you do group or individual. If you score less than 75, so 18.76 to 74.99, you could have a negative payment adjustment between -9% and 0%. If you score less than that 18.75%, you'll have a 9% negative adjustment. On the flip side, the program is payment neutral, and so penalties are what fund positive payment adjustments. So if you score 75.01 to 100 points, you will at a minimum be neutral, and you should potentially have an upside. In theory, that upside could go up to 9%. Traditionally, we don't have penalties at that rate to afford those, the upside to be that. So generally, over the last couple of years, I would say most people have landed at about 1.5–2%. on the upside. So what looked like a great opportunity to really maximize and capitalize on payments, particularly after you might hear people talk about exceptional performance bonuses, those expired. And so going forward, you really are limited by the amount of penalties. And as Martie referenced, the number of people who are excluded, and then through other circumstances may not be required to report. It really has been a nominal increase.
So Laura, again, just to provide perspective, this is performance year 21. 600,000 clinicians received upward adjustments as high as 2.34%. 74,000 received neutral adjustments. They reported, but they scored in that particular area. Different numbers in 2021, but for comparison's sake. 23,000 had negative adjustments up to 9%. So you kind of get a perspective that most folks that they report are generally scoring at a level they're getting a small bonus payment.
Correct. And over the years, the threshold has increased. The hurdle to get over to report was lower. It has gradually increased as the program has progressed. But certainly there's a good opportunity, I think, to avoid penalty. And but unfortunately, because it is easier to do that or able to do that, that also puts a cap on that upside that others might expect. So digging into quality, I think, one of the challenges, particularly with quality dropping to 30% from a weighting perspective, I think it's in the top two, promoting interoperability is the other one, where you spend a lot of time and energy to perform. Takes the performance period is a full year, January 1st through December 31st, and really working to aggregate information that impacts operations, it impacts clinical team, it impacts your use of IT and your EMR implementation and your EMR optimization, and making sure that your providers are performing the measures, they're documenting in the right place to capture the measures, that you're evaluating the scoring on the measures, and then you're submitting. So as the weight for all of that effort has gone down, it feels a little incongruous between the time that you spend to maximize this quadrant or component compared to the weighting that it now has. There are a number of opportunities and ways to collect information. So you see those listed here. Most of these feed through utilization of your electronic health record, but there are providers within a small, particularly in a small practice, that are allowed to provide and aggregate their quality data using claims. They're adding a CPT or a HCPCS code onto their claim with a corresponding visit, and it's getting accumulated in the background by CMS. And then some that are using the CAPS for MIPS survey, which is can replace a quality measure. It's a separate enrollment process where it really is surveying patients about their patient experience and their health experience. There is a data completeness requirement. So even though this is a CMS program, the reporting for quality requires that you report on the selected quality measures for all payers and all patients. Doesn't matter who the insurance carrier is for those patients, it's 100% of your patient population that you're supposed to be getting the data for. But from a data completeness perspective, they consider the data complete if you have reported on and aggregated information for at least 75%. That was each program year. They proposed new benchmarks and thresholds in 2023. They finalized it for this current performance year of 2024. We know that it's going to hold steady for 25, and then 26 was also finalized to hold steady at 75. At one point, they were looking to increase that to 80%. I referenced this before, but you must report on 6 quality measures, one of which must be an outcome or a high priority measure, or there are specialty measure sets. And if you choose to do that, then you have to report on all the measures included in that particular set. If there's less than 6, that's fine. You just report on however many are there. You just can't exclude any of those measures. So the measure sets were included to assist providers with honing in on the quality measures that fit for their particular specialty. There are 198 quality measures. They've been up over 200. They come and they go, they get expanded, deleted, all of these kind of moving parts related to those. So where on the front end, people were worried they wouldn't have enough to report on the back end, there's almost too many to choose from for meaningful reporting. which leads to the MVPs, the MIPS value pathways we'll talk about shortly. In the background, CMS is also scoring on 4 administrative measures, as you see here. They're calculating that solely based from your claims data, nothing for you to do. But when you get your reports for your providers in your organization, you will see how they aggregated the information and how your providers scored on those particular measures. All of those roll up into the quality quadrant. From a scoring perspective on the measures that you choose, there are published benchmarks. They're available on the QPP website so that you can see what an acceptable score is for each particular measure. And it varies by measure. It varies based on the utilization of the measure and how many people are pouring into it. Some measures have been refined to such extent that they've become topped out and they are no longer scored. So they've moved the needle. Medication reconciliation is one that a lot of people do. So the score for doing that is less now. So you really have to be strategic in evaluating measures that your providers can perform, that you can aggregate data on and capture the data in your EMR in a meaningful way, and that you can score well on, especially in order to get the appropriate number of points. So if you chose all measures that were easy to do that have low scores, then you're going to score low at the end of the day. If you choose 9 measures and you're not sure, you can submit 9 and CMS will score they'll take the best 6 out of whatever it is that you submit. For small practices, I referenced earlier, they have some special considerations. They get an additional 6 bonus points if they submit at least 1 measure. And a small practice for our purposes defined as a practice with less than 15 providers. You can earn up to 10 additional percentage points based on improvement in the quality category. So when we first started off, it was just a matter of did you report or not report? And then the scoring came in, and now improvement on, longitudinally, did you improve in from this year compared to last year in your performance on those measures? So you can earn additional measures for those. And for providers who are facility-based, the hospital, if the facility has a hospital value-based purchasing program score, those providers can elect by not reporting to take on that hospital score. So that may relieve some burden. Part of the reason is a facility-based provider doesn't necessarily have access, for example, to the EMR to aggregate the data to submit reports and such. So if you are a facility-based provider and you feel good about your hospital's value-based purchasing program score, you can elect to, attach to that score and carry it on as your own through really, you don't have to register for that. It happens unless you submit information. So that was the first 30%. Shifting to our second 30% in the cost category, you don't have to do anything related to cost. CMS does all of this through your administrative, by calculating it off your claims from an administrative basis. There are 29 cost-based measures available for 2024, and that includes a mix of episode-based measures and then population-based measures. If an entity, there are case minimums for each of those. So if an entity doesn't meet the case minimum for any of the 29 measures, then that category is automatically reweighted, and that 30% associated with cost gets redistributed to other quadrants. And there's a whole table, a lot of if-thens as to how that reweighting occurs. So if that's applicable to your entity, you certainly can see what that algorithm looks like to know. There is a maximum of 1 percentage point, again, related to improvement. So if your organization were to materially improve on a cost measurement, then you can get up to 1 percentage point bonus, if you will, from that. And then the facility-based scoring mimics what we just talked about from a quality perspective. Promoting interoperability, if you've been in the healthcare space and around electronic health records in particular, meaningful use is a term that will ring a bell for you. And promoting interoperability is essentially the meaningful use measures. The performance period for PI is 180 continuous days or more during the calendar year. So any 180 days you can choose. It could be at the beginning, middle, end, whatever. That's not mandated, just that it's 180 continuous days. It requires the use of EHRs that meet certification criteria. at this designation. So most providers, you'll hear that they are CERT, CERT applicable, and they meet the CERT requirements. And so they have sunset, older models that are no longer contemporary and considered meeting this requirement. But most of the EMRs, EHRs are heavily invested in making sure they have that certification. There are a number of factors that roll under PI, but really at the end of the day, if we're to summarize them, you've got to be able to reply yes to certain attestations related to information blocking, security risk analysis, and then safer guides. That HIPAA security risk assessment, part of PI is attesting that your organization has done a HIPAA security risk assessment, and that's done on an annual basis. So that's a key. I think that kind of slides under the radar for some folks, so pointing that out. There is automatic reweighting, again, for those providers who are in a setting where they don't control their EHR. And so that could be social workers, ASCs, hospital-based providers, and non-patient facing. And then also small practices can get that automatic reweighting. No required application. We'll talk about some applications in a minute for some special exceptions. This happens automatically unless you submit information for PI. I do want to call out, social workers are currently the only provider type, clinician type, that are now automatically reweighted. There were, the number of providers that had that status has decreased over the years. And so with 2024, clinical social workers are the only ones remaining on that list. From a scoring perspective, there's a numerator. So each time that the activity is performed, divided by a denominator every time that activity should have been performed. That gives a performance rate for a particular measure, and then that's multiplied by the total points available for the measure to get that scoring. If a measure requires a yes or no answer, then all the points for that measure are awarded if the answer is yes, assuming that you've performed the activity, you've got the documentation to support it. There are full points available for public health and clinical data exchange if a yes is submitted, or one yes and one exclusion if there's an excluded reason that you are not doing that. Just answering no will not get you those points. And you must report on all required measures or the score will default to 0. As with the others, there are bonus point options. You can earn five bonus points for submitting yes to some of the information and reporting that you see here, if that's applicable in your organization. The next and last quadrant that is to look at is the improvement activities. That is required for a 90-day continuous day performance period. Any 90 days, again, during the calendar year 2024, it certainly can be more. There are different activities. There's 106 different activities to choose from in order to hit the full complement for the measure. And that performance period can be different depending on the activity. They don't all have to be performed for the same 90-day period. Generally, that activities are weighted based on, obviously, the involvement and the lift to do those. And so to get your points, you would need 2 high-weighted activities, 1 high, 2 medium, 4 medium, etc., to get to the necessary score. And there are some special statuses that may impact this. So for example, providers that are in a small practice, they're in a HIPSA or a rural area, get double points for each activity that they do. So they would essentially be half of these as they go. In order to count an activity as being met, then at least for a group, 50% of the clinicians in the group would have to be performing the activity for those continuous 90 days. Once upon a time, it only required 1 provider to do it for 90 days, regardless of the number of providers in the organization. So as we mentioned earlier, they've kind of ratcheted up the requirements and thresholds, and this is one of those examples. There are certain times that there may be an extreme and uncontrollable circumstance, so a MIPS EUC exception, and those are by application. Those applications can be submitted currently until December 31st of 2024, 8 p.m. Eastern time. A lot of times that gets extended into early January if there's certain pieces going on. So, but for all intents and purposes, you can submit it now up to December 31st. These are intended for rare events that are outside of your control that prohibit you from being able to successfully report for MIPS. So over the last couple of years, obviously we've had a pandemic. There were some across the board exceptions that CMS took, and then over the last 2 years, you could apply for COVID related exceptions. With a great deal, they were pretty liberal in granting those exceptions. They do note, however, the PHE has ended, and though COVID-19 is no longer an exception request that they will consider for 2024. You log into the Healthcare Quality Information System through your access roles, the same way you would do to get your roster that we talked about for QPP participation, and through HARP in order to submit that. It's a pretty simple form to submit. You give the reason, and if you are accepted, then you don't have to do anything else. You have no other reporting obligation. If you apply and are accepted and then later submit information, they will score that information and it will trump the EUC that might have been granted. So if you think you might need it and you want to go ahead and file to see if you get it, and then you subsequently determine that you can submit information and report successfully, you can always submit later on and override, if you will, the EUC that was granted. As these are also intended for those circumstances where there are extreme circumstances. So for example, the wildfires in Hawaii, if an area is declared it kind of ties to the federal disaster areas, but CMS designated region. So areas that have been affected by earthquakes or hurricanes often are automatically applied. CMS automatically grants that exception. And again, those organizations can still choose to submit information and be scored if they want to go for the positive adjustment on their fee schedule, or they just don't have to do anything and are excluded from reporting. So you would want to know clearly where your providers fall. If you fall under one of these, this will not necessarily show up on the individual provider lookup. You would be looking at a list of the CMS designated regions to see if your region falls into one of those, for example. There is also a promoting interoperability exception that organizations and providers can apply for, same date for the due date. They are, again, for specific exceptions. They have these 4 reasons. You don't have internet connectivity, you have a decertified EHR, you have a disaster, a practice closure, financial distress, your vendor, your EMR vendor is no longer viable, or you lack control over the cert. So you're a provider who can't, you might be an employed provider who has no opportunity to control the EMR being used in the practice, for example. CMS notes that just lacking a cert approved EMR, EHR does not qualify. And they also are very specific that just transitioning from one EMR, EHR platform to another is not enough to be granted this exception. They have specific the expectations that you will just simply merge information from both systems to get to one data file for that particular filing. If this exception is granted, then that PI category is reweighted to other categories, and that too is on that algorithm that we referred to earlier on reweighting. So let's touch base for just a moment on MIPS value pathways. We'll leave some time for Martie to talk about our APMs. So when you think about, I mentioned the 200 quality measures, for example, available to providers to choose from. Those were created organically to ensure that all the providers have plenty to choose from in their reporting. And what happens at the end of the day is providers of the same specialty can choose measures that are completely different from other providers in their same specialty. So through that process, we lost the ability to compare performance between 2 nephrologists or 2 neurologists or 2 whatever ologist you're looking at. So one of the goals of transitioning to MIPS value pathways is to narrow down the quality measures and activities that are selected so that we can get to some point of comparability. How can we compare how this provider is performing from a cost and quality perspective compared to this provider if the other setting, they're the same specialty, for example, is equal. And so you see in 2022, CMS introduced MIPS, and they put out 3 or 4 MIPS value pathways and have begun to increase those with the goal of getting to a future where there is no traditional MIPS. In the early introductions, that future had a date. There was some speculation that traditional MIPS would be sunset in 2027. In the later updates from an MVP perspective, that 2027 has been removed, and so it just references that it could end in the future. So we don't have any kind of date certain as to when traditional MIPS might go away. And if you stayed in MIPS versus an APM, that the use of the MIPS value pathways would become mandatory. So we fully, every update in the register, they indicate commitment to moving to these MVPs, so we don't think those are going to be dissolved, but the true date to get there is unknown at this point. For MIPS value pathways, and in our poll, we had a handful of attendees who look like they are going this MVP route. That's an affirmative registration. You have to log in and register between April 1st, so it's open, and register by December the 2nd, 2024. If you're going to use CAHPS for MIPS survey as one of your measures, then you have to have that registration completed by June the 30th, so just pointing out that that deadline is approaching. If you register for MIPS MVPs, you can make changes to that registration up to November 30th of 2024. And really the goal is to select one that fits for your entity and organization. When you register, you have to choose what population health measure you're going to report on, as well as the outcomes-based measure. You have to, at the very beginning, you have to assign which ones you're going to choose from. At the end of the day, you can't report on an MVP that you didn't register for. So you want to be selective in choosing one that fits to the best of your ability what you're going to be able to report on. And there are the abilities to do subgroups. So if you are multi-specialty and you have a group of primary care and OBGYN and urology, you can elect to create subgroups so that those providers are all evaluated as subgroups. It's not required at this point, but they do anticipate that becoming a future requirement, so that, again, so they can have comparability based on types of providers. You see here just a listing of MVPs. They added, I think, 7 this year in 2024. So it's been a slow build up. It was 3, and then I think they added 4, and then they added 6 or 7 this year. So I think that's part of what's taking the target of 2027 maybe being delayed, because these are going through a lot of input, getting information from the specialty societies, really trying to identify the types of providers that would be reporting, the types of measures that would be appropriate from all of the different categories in order to successfully report. You see here that's similar to the conversation we had with traditional MIPS. There are a requirement, some differences though, and I think incentives, CMS has put in some incentives to use these and transition to these. Instead of 6 quality measures that you have to have for traditional, you can use, you're required to report on 4. Again, when you choose a specific topic or MVP specifically, it gives you the list of measures to choose from. So it goes from the 198 measures to 20, and you choose 4 from the 20, one of which still must be an outcome or a high priority measure. And then this can include some that are calculated by CMS through claims if that's available within the MVP. Similarly, you have the improvement activity category where you choose from a narrowed down list of available IA activities. CMS is still calculating cost in the background. And then we reference the population health measures that you choose on the front end as to what you're going to report on. That's kind of a foundational layer, so you'll see that in every MVP. And then the promoting interoperability category is similar to what we talked about. And here's just a deeper dive. I didn't go this deep on the other related to, but you see the categories and the measures that you're considering when you do promoting interoperability. Martie, what do you have to share about APMs and advanced APMs?
Well, so this is the other half of the quality payment program. So MIPS is focused on those providers who continue to bill strictly fee-for-service reimbursement that they report on quality and promoting interoperability and performance improvement activities as they relate to those fee-for-service reimbursements. But back in 2015, when Congress passed MACRA, which gave us the QPP, there was an interest in creating an incentive structure to push providers toward alternative payment models. So where you have adjustments to payments based on quality and efficiency or population-based payments. So what you see on your screen is a APM framework that has been developed by an organization called the Health Payment and Learning Action Network, the LAN, it is frequently referred to. This is a working group of provider organizations, payer organizations, policy advocates that have really been focused on enabling the transition to alternative payment models. And very early in their discussions, they said, well, if we're going to incentivize movement to APMs, we need to start with explaining what an APM is. And one size does not fit all. And so they created this matrix to help us understand this progression through alternative payment models. And you start with category 1, which is just straight up fee-for-service reimbursement. Category 2 is sort of these early iterations of fee-for-service, but adjusting the payments based on quality and value. And category 2C is really where MIPS lives. It's a pay-for-performance program. So it enhances payments or reduces payments based on your score on those quality and efficiency measures. Category 3 are where things become more alternative to traditional fee-for-service reimbursement. We still have a fee-for-service chassis, but we're adding program elements for provider organizations that can lead to a share of savings, either generating from a shared savings program, an episodic payment model. And these can be either programs that have no downside risk, so only upside if you perform well, or there is downside risk, creating even a more significant incentive that if you don't meet certain metrics, you're then actually paying dollars back to the payer. And then finally, in category 4, we have population-based payment measures. This can be a condition-specific measure. So if you are managing all of a patient's primary care, for example, you're paid a flat fee for providing those primary care services, or you even get into sort of global budgets for an assigned population. So that's sort of the categories through when we talk about APMs that we're looking at. And as we start talking about how APMs work with the quality payment program, you'll see these are really going to impact primarily categories 3 and 4. Next slide, Lori. So we use the term APM broadly, but in fact, there are 2 very distinct categories of how APMs are treated under the quality payment program. There are MIPS APMs and then advanced APMs. MIPS APMs, very broadly defined, are programs that hold participants accountable for cost and quality provided to Medicare beneficiaries. So these MIPS APMs are always traditional Medicare APMs. And you see the link for the complete list of currently recognized Medicare MIPS APMs. Generally speaking, participants in MIPS APMs are still subject to MIPS payment adjustments. It's a question of how you calculate that adjustment that comes into play. There should be an asterisk here because certain types of participants in certain types of MIPS APM actually roll out of MIPS reporting and MIPS adjustments in favor of the advanced alternative payment model adjustment, which we'll talk about shortly. The MIPS score is calculated, as I said, on a different methodology. That's referred to as the APM performance pathway. And if you are a participant in a MIPS APM and your organization through which you participate in the APM is utilizing the APM performance pathway, you're still given a choice that you can either elect to be scored under the APM performance pathway and not do traditional MIPS reporting, Or you can hedge your bets and go ahead through the process of reporting under MIPS, and either as a group or an individual. And at the end of the day, CMS is going to compare your score under the two and give you the higher score. So it's not a mandatory pathway, but it is an alternative where you can still, again, hedge your bets. So let's talk about advanced APMs, which is again, it's a subset of MIPS APMs plus other payer alternative payment models that have been recognized as CMS as meeting the criteria for advanced APMs. So again, subset of MIPS APMs, we'll talk about what those subset is, but then also advanced APMs include other payers, so Medicaid, MA plans, commercial payers that have created APMs that have been presented to CMS, and CMS has determined that they meet 3 criteria to be an advanced APM. It requires the use of a certified EHR to participate in that APM. That there have to be payment adjustments that are based on performance on specified quality measures. And third, there has to be financial risk for the participants. So again, if a payer has created an alternative payment model, it wants to create that additional incentive for participation by providers in that model, it can present the model to CMS and have it deemed to be an advanced APM. So if you are in at one of these subset MIPS APM or one of these other alternative payment models, you're not there yet. You're only halfway there, because you are either going to be determined to be a qualifying APM participant, or the term we use is a QP, or you're going to be deemed a partial qualifying APM participant, or referred to as partial QPs. So the difference is if you are a QP in an advanced APM, you are, and that's our category of folks that are excused from reporting traditional MVP or MIPS. So either way, you're out of the MIPS reporting requirement, and in place of the MIPS adjustment, you receive the advanced APM payment adjustment. If you're a qualifying APM participant, you have an option of either opting out of MIPS and taking the 0 adjustment. So similar to a eligible clinician that doesn't meet the low volume threshold, you're just effectively out of the program and you don't receive any adjustment. So, or you can elect to participate in regular traditional MIPS. So it's a effectively get out of MIPS free card if you qualify as a partial APM. That's the basics. Let's try and break this down a little more. Lori, next slide.
And Martie, I would add too, when we were talking about looking up providers, if you drop in an NPI and a provider is in an APM or they're a QP or a partial QP, that information will also show up on the lookup, so you can have some insight from where they are. And some of these assessments are lagging, right? They're late in the year that these determinations are made, so you have to look several times during the year to get the right in picture.
Right. We have specific snapshots. So let's start with MIPS APMs. Okay, remember, these are the folks that are going to report on the APM pathway. And it includes the ones we're most familiar with that qualify as MIPS APMs are going to be the Medicare Shared Savings Programs, basic track levels A through D. So that includes the no risk MSSP options as well as the lower risk MSSP options. A MIPS eligible clinician that participates in one of these MIPS APMs, again, can elect to have the APM entity's MIPS score calculated for them, or again, report separately. So how do you know if you are a participant in a MIPS APM? You're going to have your NPI appear on that APM participant list or the affiliated practitioner list. There's different names for different types of programs, at least for one snapshot date. So you see there the snapshots for 2024. It changes from year to year when they take the snapshots, but our first snapshot for 2024 is going to be published in July. We'll do it again in October, then December, and then we have a very back-end measure. We actually look once again in March of 2025, when CMS is finally beginning the process of calculating MIPS scores. They'll do one last look back in March of 2025. If you're in any of those snapshots, if you kind of photobombing any list, you're going to make it for that entire year. And it's the same MPI lookup tool, as Lori said, as the others. If you elect to report traditional MIPS, and in addition to being a participant in a MIPS APM, you're going to get the higher score of the two. What we know historically, since the MIPS pathway was introduced, is that those MPIs that participate under a MIPS APM tend to have higher scores than those that are reporting either as individuals or groups. If you are an MPI that bills under multiple TINs, you're still going to have to report traditional MIPS or MVP MIPS for the TINs that do not participate in the MIPS APM. And we do have folks, for whatever reason, end up in this category that they've reassigned to Group A and to Group B. Group A participates in a MIPS APM, Group B does not. Since you're going to be paid through both organizations, remember, it's always an MPI-TIN combination. And so your adjustment is unique to that MPI-TIN combination. And so you would end up reporting over here separately than what we do under the MIPS pathway. So the APM performance pathway, how it's actually scored, we put cost at 0. The idea being that you're already in an APM, and that APM is the incentive to reduce costs, enhance efficiency, so we score that at 0. Quality is that good old 50% that it used to be back in 2019, but you're not reporting quality measures under MIPS. Instead, you're reporting the MIPS APM quality measures. So those are distinct, right? We have what we report quality measures for MIPS, but then within each MIPS APM, there are a set of programmatic quality measures that determine the entity's performance under that MIPS APM. So for MSSP, we have the set of MSSP quality measures changing significantly in 2025, as you know, but it's your score on those MSSP quality measures that's then going to determine the score on that APM performance pathway. Performance improvement is 20%, but you automatically get full credit because if you are in an APM, you're doing what we want you to do. So we're going to give you full performance. And then promoting interoperability sets at 30%. And this is reported just as old MIPS is. So this is still the reporting obligation that the individual or the group has, regardless of its participation in the MIPS APM. It's still going to report on promoting interoperability. The APM entity's score then is derived from its participant score. And herein is the reason that a lot of folks elect to still report MIPS, even if they are in a Medicaid APM, since they're having to already report on the promoting interoperability component. Next slide. So let's talk about the advanced APMs. Again, the most common advanced APMs include the MSSP basic track level E and the enhanced track. So those are the higher risk versions of the MSSP, as well as bundled payment for care improvement and the ACO REACH program, formerly known as direct contracting. Those are our most common advanced APMs. Again, there's a list maintained by CMS of additional commercial-based APMs as well. A qualifying participant in an advanced APM, a QP, has to receive at least 75% of their Medicare Part B payments, or see at least 50% of their traditional Medicare beneficiaries through the advanced APM entity during the QP performance period. Those percentages will go up in 2026, but that's where we hold for 2024, 2025. We take the same snapshot as we do for the MIPS APM participation. And again, you may qualify to meet these thresholds through this all payer and other payer option. Again, that's Medicare participation plus other non-Medicare payers. The short answer is, if you're in a Medicare Shared Savings Program, so that's going to be the MSSP programs, ACO REACH, because all of your traditional Medicare beneficiaries are part of the attribution model, you effectively end up becoming a QP. The issue arises with episodic payment models. So if you're participating in the bundled payment for care improvement, is there a sufficient number of your patient population that is subject to that episodic payment model that it qualifies you as a QP? So that's where the mix is and all of that. If you are a QP, your payment adjustment for performance year 2024, so performance in 24, payment in 26, is going to be about a 2.63% increase in your Part B payments in 2026. Prior to this year, well, 2022 performance year and before, if you were an advanced APM QP, it was a 5% positive adjustment. That was statutory. It was set to sunset for 2024. Congress swooped in, it was set to sunset in 2023. I apologize. Congress swooped in and said, no, we're going to have a 3% payment adjustment for advanced APM participants for 2023. That was again set to go away for 2024, and the Consolidated Appropriations Act of 2024, which is referred to as the minibus bill. I love that terminology. But that legislation said, well, we'll still afford them a small adjustment in 2024. That added with a conversion factor update results in that 2.63 increase for 2024-2026 payment year. For 2025 and beyond, the advantage of being in a QP for an advanced APM is that you're going to have a higher conversion factor update. What begins in 2025 is a stair-step increase in the conversion factor of 0.25% for all providers. Now, granted, that's not where the conversion factor usually ends up because there are other adjustments made for budget neutrality. But if you have today, the conversion factor is what, about $32.50? I can't remember. But next year it will be 0.25% higher, and then subject, of course, to the other adjustments. But if you are in an advanced APM, you actually see a 0.75% increase in the conversion factor year over year, so 0.5% more than those that do not constitute advanced APMs. If you're a qualifying APM participant, you see that that's lower percentages. And again, as we said, it's just an opt-out of MIPS. You don't get the higher payment adjustment. Lori, next slide.
MIPS and action items. So we just wanted to leave everybody with some thoughts on, really what do you do with all this information? You have a lot of options and determine your MIPS pathway for 2024. Hopefully you're well on that way since we're in May. But again, each year it may change. And so I think evaluating each year as to what's going on, leveraging really your operational, your clinical quality information systems team members is your best opportunity for success. This is not just a quality program. It's not just an IT program. It really has to be holistic with your organization in order to make it to capitalize and perform the best you can, but also make it palatable to your providers and clinicians as they're seeing patients and helping aggregate information. If you are considering an MVP, make sure that your vendor can support the MVP that you're looking at, and specifically related to data aggregation and reporting. Not all vendors can support all quality measures. And so you want to know that they can handle the ones that you are looking to aggregate, and evaluate those benefits and risks of early adoption. Is that the right thing for you, depending on a variety of factors within your organization? As always, evaluating those APM options. Martie's made a case for, increased reimbursement. You can opt out of some of the traditional reporting. It's where Medicare would ultimately like us to go as a provider group, just to from a steering perspective. So I think it will continue to make those sweeten the deal, if you will, for those. Evaluate that strategy 2 to 3 years. We'll see where they go with MIPS, what they do with traditional. And then as a last marker, just remember that they each year put out updates to MIPS, and that's, you know, in the proposed rule, you have the opportunity to comment, and we really want to advocate for it has been impactful in steering the program. And so if it's important in your organization, you have strong opinions, then make your voice be heard in that comment period, which should be July. Usually we get the rule kind of July-ish, and so you have 60 days from there to do so. So hopefully you found this conversation helpful as you're trying to get your arms wrapped around this world we call MIPS and APMs. And Martie, I think we have some reminders.
Yep, every 2 weeks we come back here and talk about other fun things. So in 2 weeks, I'm going to be joined by 2 other PYA colleagues, Miriam Murray and Katie Coswell, to talk about the social determinants of health. And then on June 19th, we'll be talking about healthcare privacy update. So I hope you'll be able to join us for those webinars as well. Trevor, back to you.
Thanks to our presenters, Martie and Lori. Later today, you will receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.